Good afternoon. This is Shirley Hevlin, HFMA Certification Administrator. Welcome to this HFMA webinar, Lessons from COVID-19, Strengthening Supply Chains, Lowering Risk, sponsored by GHX. It is my pleasure today to welcome the speakers. Mary Beth Briscoe is the former National Chair, HFMA, and AHRMM board member. She has more than 30 years of experience in healthcare finance in various senior management positions. Before joining the University of Miami, Mary Beth served as the Chief Financial Officer of UAB University Hospital and UAB Medicine Clinical Operations. Steve Kiewit is Chief Commercial Officer for Interlair and AHRMM's Chair-elect. He is responsible for ensuring the integrated commercial success of Interlair through business and market share growth with direct oversight of sales, account management, marketing, business development, client success, and customer service teams. Karen Conway is Vice President Healthcare Value for GHX and former Chair, AHRMM. As Vice President, she explores how improved data quality and visibility can optimize the identification and delivery of the products and services that provide the most value to patients. With that, Karen, I'll turn the presentation over to you.
Thank you so much, Shirley, and thank you everybody who has joined today, because we know full well how very, very busy and such a critical time in healthcare. So thank you so much for taking the time. And I want to thank my two presenters, Mary Beth Briscoe and Steve Kiewit, who bring a wealth of experience. For those who don't know AHRMM, which stands for the Association for Healthcare Resource and Materials Management, it is the supply chain organization, and we believe the leading supply chain organization, and we're part of the American Hospital Association. So we're hoping today that we can bring together some critical thinking related to both finance, particularly given Mary Beth's long tenure and experience as a CFO, along with Steve and my experience in terms of leading supply chain initiatives. We're going to talk a little bit about the realities of pandemics and how they impact supply chains, because the rules are different and certainly the challenges are, but there are some very fundamental things in supply chain that we believe can help us mitigate the risk of future pandemics, as well as shore up the supply chain in routine practice. We're going to talk about some real-world, real-time lessons, because we are indeed all in this COVID-19 classroom and learning and trying to apply these lessons, whether it's financially, whether it's clinically, whether it's from the supply chain, whether it's infection control, et cetera, in real time as we move through this. We're going to share some very immediate strategies you can use. We're also going to look at some of these longer-term strategies that we hope you can put in place. And most importantly, how can finance executives and their organizations both support but also benefit from having a stronger, more resilient, and strategically focused supply chain? So the reality is this is not our first rodeo, nor is it our last. This really takes you back to the Black Plague back in 1300s, but takes you forward. And the one thing I want to point out is that, one, we are seeing more of these epidemics that could potentially become pandemics occurring since 1980. Scientists are predicting more, and in all cases, they are multi-year events. So certainly we want to get to that point where we can prevent with vaccines, but the best we're going to be able to do, probably for a couple of years, is to be able to manage the ability to take care of patients, to control the spread, and to take care of those very important healthcare workers on the front line. And we would also say those important people behind them, whether they're working in operational or in financial roles. So what has happened to us? And this really is this perfect storm, because we've had H1N1 and we did experience supply shortages then. SARS impacted different parts of the world more. It's interesting as I've watched the Canadian response at the provincial level in the early days of COVID-19, they were taking action right away because they were hit hard by SARS. And I believe that they took some of those very important lessons. But what we had here is that if you looked at the data early on, and some of these stories that I've got the sources here for you, were showing that in China, they were starting to go in and say, we're buying up all of the output of these critical products like personal protection equipment or PPE from, because some of that would be used and sold in China, but a lot of it would be sold into markets around the world. And we even started seeing in January, medical workers in China were already saying, hey, we don't have enough of these critical PPE. And then what happened is as the disease spreads, you start seeing this demand everywhere. At the same time, productivity is declining because, one, in China and in elsewhere, they're starting to shut down production to try to minimize the spread of the disease, or you have a compromised, you have an ill, or you have a fearful workplace. In some cases, for example, some of the medical device manufacturers that I've spoken to have said, we saw the problem in China, so we quickly tried to ramp up the production in other places, say in France, where the disease had not spread significantly yet, but the word was out, and there were people who were, quite frankly, fearful to go to work. And so, again, you have this production. Plus, you have transportation. So it's not only about having the product, but being able to get that product to where it is needed. And as you started to see the airlines starting to curtail their flights, a lot of times these products sit in the belly of those passenger planes as they're coming forward. So we had some early signs, but I think lessons learned, we will start looking at those early signs, and there are multiple places we could see it. We have learned lessons in other industries. The Japanese earthquake and tsunami that happened back in 2011 had a significant impact on the automobile industry and on the electronics industry. Just one example, there was a supplier of brakes. It was the sole supplier of brakes for a major Japanese automaker. And because its plant was destroyed in the earthquake and tsunami, they had to shut down 18 different facilities for about 2 weeks. And that resulted in about a $325 million loss for that company. Well, in healthcare, we can't shut down healthcare, but we certainly have actually seen in some cases patients who have been staying away from the hospital or because they're, quite frankly, afraid. And unfortunately, now we're seeing some of those patients, say, with serious chronic diseases who are now showing up in ambulance, far sicker, who absolutely do need that care. And of course, and we'll be talking about this, that desire to get back somewhat to business as usual, and some of those kinds of surgeries and procedures that are critical for the patient and obviously critical for the bottom line of the hospital. We certainly learned lessons in healthcare from the supply disruptions from Maria. The map you see on the right, that's a map of the 54 different pharmaceutical and medical device manufacturing facilities located on the island of Puerto Rico. As a result of that, we saw significant shortages in IV bags. And I have a link on here to some discussion from the CEO of Baxter, which was impacted by that shortage, and what they have done since. They expanded their manufacturing, so it's not just in Puerto Rico, but it's also in Mexico. They're monitoring order levels to one, see spikes, but they're also trying to prevent hoarding. They're trying to help their upstream suppliers get back into production. They're identifying alternative suppliers that they need. So they're dealing, they have dealt with their own supply chain disruption issues. And that's probably the key message of all of this, is supply chain is not something that just happens in your hospital, in your shared service center. It is something that extends end to end from the point of bringing in the different components and raw materials to produce a product all the way through to those products being used in patients, you know, in cases like implantable devices, walking out of the hospital inside that patient. Certainly, they've been looking at different shipping routes as well. So the key is, how do we learn from these lessons? And the fact is, we've known about these challenges. These are just a couple of examples. Bill Gates, who's been doing a lot of television interviews and YouTube, et cetera, talked about this need for us at a global level to develop these lists of supplies that would be needed in an epidemic. And so then we can determine, what do we need to have in stockpiles? Where can we get these supplies? And it was just in December that Dr. Kadlec, who is the Assistant Secretary for Emergency Preparedness and Response, was speaking to a House committee about the fact that global manufacturing capacity would not be able to keep up with the demands of a pandemic of this size. So we're going to go through some top 10 strategies, and after the webinar, we also have a document that details them along with some references, which are also, you'll see on the slides. So I'm going to jump right into the first one, which is really about, in good disaster planning, disaster preparedness, crisis management, it's all about how fast you can act and how effectively you can act when it happens. So it is about thinking about what could happen. Now, Governor Mike Leavitt, who used to be the Secretary of Health and Human Services, he always uses this line, which is basically, anything you do in advance of a pandemic is alarmist. Anything you do during a pandemic is not enough. But you start thinking through these things. And probably the most important factor is not only to think about what's likely going to come up, but it's doing it in partnership with your internal and external stakeholders, because it is only through that process, and we would recommend a tabletop exercise, is that when you start to meet these individuals, they're starting to bring to light issues that you might not have thought about, but you're establishing relationships, whether that's relationships with other leaders within your own healthcare system, or whether that's relationship with your peers in other hospitals and healthcare systems, whether it's the public health leaders, the heads of local and state governments, and some of the businesses upon which we will need to rely and are relying now, who are being able to produce some of these critical products that are in shortage. Then as you think through these different scenarios, think about the different kinds of products that are going to be used. And they're going to differ. In some cases, you know, you have some similarities between, for example, when we were fighting Ebola and now fighting COVID-19. But in other cases, it depends on how that disease is spread. So if it's a bloodborne disease, or it's something that, you know, from respiratory, that you can catch it. It's also, how do you treat? And it's also, what kinds of individuals do you need to have on the front line? You need to also think about what actually drives the supply usage. Because, for example, with personal protective equipment, the real driver is not your patient census or your anticipated patient demand. It's driven more by how many people you have on the front lines working, which is one of the reasons why a number of organizations have relied on more overtime, so that they're limiting the number of people. Or it is, if you're using a ventilator more, all of a sudden you're going to start needing to use more of the consumables, things like the HEPA filters. Or a lot of organizations have been pulling the equipment, the IV pumps, the patient monitoring equipment, out into the hallway, so that nurses don't have to don and doff the precious personal protection equipment, because they don't have to go always into the patient room. But suddenly we had a shortage for a while of these longer 10-foot IV lines. So it's kind of thinking through that as a system And then also developing these supply lists for as you're looking to expand capacity, whether you're turning a single patient room into a double one, an OR, into an ICU, or you're setting up a field hospital, say, at a convention center. One of the things that COVID-19 and the shortages that we have experienced has brought to light are some of our current supply chain practices. Now, this is not to say that these practices are wrong, but this is to say that these practices do come with associated risks. And Mary Beth and Steve are going to be talking about that a little bit as we look at the various ways that we need to measure supply chain. But it's also that just in time, now we have seen, for example, over the last 8 years, if you look at the use of just-in-time through a distributor, just-in-time orders through a distributor versus just-in-time, just regular kind of distributor orders, we've seen the just-in-time orders go up by a factor of 3. But just-in-time also impacts manufacturing. So the vendors that you're buying your products from, the manufacturers that are producing those products, they're also doing just-in-time manufacturing. It really started back in the 70s with Toyota, and it's this concept, that the brake system doesn't show up for the car until right before you need it. Well, think about what happened with the earthquake and tsunami and the brake system for that Japanese automaker. It's a matter of, and so we've outsourced a lot of this, and it can deliver significant savings. And certainly we have a lot of hospitals and healthcare systems that don't have the warehouse space, if you will, to even be holding the inventory, let alone the desire to reduce the carrying costs. But we need to understand what are these trade-offs when we're trying to lean out and reduce the cost of the supply chain as much as possible. So these are the kinds of things you start thinking about when you start looking at how do I minimize my upstream supply risk. I mentioned the Japanese earthquake and tsunami, and the fact that one of the things that did is that led manufacturers to start looking at their upstream risk. Because if you are like that Japanese automaker and you have one supplier of your brake system and that supplier goes down, you go down. So how do you look at what are my options? So, you start asking you can look at am I sole sourcing something? But even if you had 2 sources of a product, it wasn't that long ago when we had a shortage of syringes. And the problem is that multiple syringe manufacturers were relying on a single supplier for the stopper. So we have to map it up multiple tiers. And then I would argue, as you're thinking about the different things that you factor in when you're doing your new technology assessment or your value analysis, that you include this risk management, this upstream risk. And I would argue that, are you prioritizing vendors who are willing and able to give you information about potential or imminent shortages? You may have seen in the CARES Act that was passed a couple of weeks ago that there is a requirement now that medical device manufacturers report to the FDA potential or imminent shortages. This is something that pharmaceutical manufacturers have had to do for quite a while. But the reality is that just having a regulation doesn't necessarily get you all the information you need. There are some vendors that are more able to provide you this information, that are managing their risk and are willing to share. You need to understand that, of course, no manufacturer, no vendor wants to tell you, hey, I'm going to be back ordered, because they're fearful of losing the business. But if you develop those trusted relationships with them, then they know you will be back because they have helped you avert a potential problem that could impact clinical care as well as your financial health. So as you're looking at who you're doing business with and as you're developing contracts, this is a big area of discussion, and I don't think anyone has the full answer, but it really is a matter of looking at those terms and conditions. And do your contracts help you address potential shortages? If a shortage is coming, are there ways you can optimize allocations? One of the problems with that is that, you know, we also have learned that we want to make sure we're getting the products to where they need to be, when they need to be, as we're looking at care within communities, across states, across the country. And so there is this desire not to hoard, and yet there's an absolute need to make sure that you have the allocation. If you have a contract, excuse me, and you've committed to buy or spend X amount of your dollars or your percentage of your spend in a particular category with a vendor or through a group purchasing organization, you know, do you have leeway when we get into situations like this? And what we have also seen is a lot of hospitals and healthcare systems have had to turn to non-traditional suppliers. Now, these could be anything from, you know, a 3D printing company, you know, all of a sudden turning on and making shields or making these valves that allow, you know, 2 patients to be on 1 ventilator. What's interesting, you're even seeing hospitals and healthcare systems get into this business and starting to become manufacturers themselves. Or whether it's some of these folks who are, hey, I've got access to KN95 masks. That's the Chinese version of the N95 mask. Or there's the South Korean version, or there's the European version, etc. But these are not vendors you're used to working with because they've been allowed to sell now under the emergency use authorization authority of the FDA, but you don't know who they are. And the reality is, and we've been actually helping the American Hospital Association and AHRMM vet some of these, at least do an initial vetting, because unfortunately we also know there's a number of bad actors out there. So you may be using credentialing services. Your credentialing service may have some of this capability to be able to help you. Then I would add is this ability to understand inventory. Certainly, I think one thing we've seen come to light is this question of how many ventilators do we have? Where are the ventilators? How much is in different kinds of stockpiles, et cetera? What's available? Where is it? How is it coming? But we've also seen this with critical products like PPE. And the reality is that most hospitals have looked primarily, and as my friend Mary Beth will say, we've looked at PPI much more than we've looked at PPE. But as we've now seen, as we're trying to manage this, and particularly the critical financial implications of having to source significantly more product, and unfortunately in some cases, product at significantly higher unit costs, we need to understand actually how much do we have? Where is it? What's our daily burn rate? And where is the rest coming from? And this is something that other industries have not solved for, but they've made more advances in because they have been able to adopt industry standards to identify products. They've been more willing. If you think about the stories of Procter & Gamble and Walmart, where you put these individuals in the room, they're working off the same data. They're willing to share data. People have said, I don't know who works for whom when I listen to the conversations. We have historically not done that in healthcare. This is not an easy lift, but it leads to tremendous benefits. And we'll have more of a conversation about that. So what are those opportunities? And does this become a new negotiation factor? If you're able to help a manufacturer have better visibility into your anticipated consumption and your actual consumption, that gives them demand sensing data, which allows them to be improving their manufacturing. And quite frankly, we either have a problem of not enough supplies, or we have a problem where we have supplies that sit on a shelf and they expire before they're used. And that's a cost that everybody suffers from. It's one of those things that just-in-time can help with, but again, we need to apply these different kinds of things. So the other issue is to think about, as we're getting prepared for more elective procedures, and we want to bring these folks who have been sitting and waiting to come into the hospital for the care they need. And of course, these are highly profitable and very important to the bottom line. How do we get ready for these? But this isn't a matter of you just go back to normal. We really need to be thinking about, what is your anticipated demand? And what are the financial impacts? Because there will be revenue, but there's also obviously going to be expenses. What are your working capital needs, and what are your different solutions that are available? This is a great place to start conversations with your vendors, because those vendors that specialize in products for elective surgeries, for things that happen in the OR and the cath lab, they're hurting as well, and they want to get back to business. But the reality is they're experiencing their own supply chain challenges, and some of them have proactively repurposed certain production lines to be producing the products, supplies, and drugs that have been in critical shortage. So talk about that. Think about things like, again, PPE. If you don't have a fast turnaround for a test to see if a patient has the disease, then you have to have them masked. And so again, you are utilizing PPE. That's precious. And then think about where you can be doing these. If you have outpatient, or if you've invested in or are joint venturing with ambulatory surgery centers, so there are other places you can be performing these. And then, do you have the logistics capabilities to get the supplies to those various locations? So a lot of the things that we've been talking about here, I think, is the fact that in a pandemic, it's not a do-it-yourself process. It's absolutely something to do as a team sport. And the reality is, if every single hospital or healthcare system tried to make sure that they had the stock that they needed in the event of a pandemic, we couldn't afford it. We wouldn't have enough space to put it, et cetera. But I think, this is the reason that we have state stockpiles and we have strategic national stockpiles. But we've also identified that they're there to augment. They aren't the end-all, be-all. So some of the ideas people kick around are, hey, if I have those relationships with that CEO or that CFO or that supply chain leader at the other major healthcare institutions within my region, could we pool our resources? Maybe we could share stock and warehouse space, and we could make sure that that stock is being turned over. One of the issues that we had with some of the stockpiles is that product had expired or that it hadn't been serviced. So if you've got supply chain professionals and you're sharing the burden, you could be doing that together. Or investing in predictive modeling for what might be happening in your community. The risks in a community in Florida are different than the risks of a community in St. Louis. But you can identify those and you can plan. Can you work on those essential product lists together, et cetera? Can you both be identifying or together being identifying, hey, you know what? There is this apparel company that is located in our vicinity. I wonder if we were able to get them the right materials. Could they have the manufacturing capacity that maybe a down manufacturer doesn't have because they're operating at full capacity, but they've got extra material? Could we get that there? Or are there 3D printing companies? Can we be getting stock out of a nursing school that has been shut down because of social distancing, but has PPE that they've been using in the training of their students? So with that, those are just a few ideas. As I said, we've got these outlined in a top 10 strategy list. But perhaps the most important, and this is where I'd like to bring in my colleagues Steve and Mary Beth, to talk about the importance of supply chain metrics, broadening those, and understanding the risks and the trade-offs involved.
Thank you, Karen, and thank you, everybody, for being on today. And for sure, we all know that in healthcare and in supply chain organizations, we measure a lot of things, and we always have measured a lot of things. And determining what to measure and when to measure is always a little bit of sometimes driven by the circumstances that we're in at a time. So certain measures become more important or less important than others, depending on who the stakeholder is or the situation given at the time. And I think if you think through a lot of the metrics that are on this page, probably everyone is familiar with most of them or all of them. And in fact, a lot of systems and supply chains measure many, if not all of these today. And it doesn't make them inappropriate, or it doesn't make them things that we should not continue to invest time in. But a lot of what we have a tendency to measure are very tactical, operational, and efficiency driven, and doesn't always address bigger needs and things that maybe we should have known, which is the catalyst behind a project that was started with the AHRMM organization specifically. We took some lessons from what HFMA created in the NAPKEYS program, and we set on a similar journey to say what are some critical KPIs and metrics as it relates to healthcare and supply chain, where we could say these are, of everything you could measure, here are some things that are really important to measure. And we started that project last year. And then, of course, don't let a good crisis go to waste. As we're evaluating the things that we started talking about in this program and the metrics that we started talking about, we started asking the question now, well, what I wish I would have known as we sit here in the middle of a pandemic in a crisis situation. Now we start thinking about a whole bunch of things that what is data I wish I would have had? What is data I wish I had the capability of measuring? And what could I measure today, to the point that was brought up earlier around daily inventory levels or daily consumption rates or, stock out rates or sub out rates, but more than just at the facility level or the department level, how do we effectively roll that up into a system level, into a county level, regional level, state level, et cetera? So how do we open up the data sharing capabilities for some of these numbers and metrics so that we have a better lens on how to respond to things that happen? And I think a lot of great pandemic planning and disaster planning happens. I've seen great success stories from health systems that have gone and taken on disasters such as floods and hurricanes and tornadoes and many other things. And we do it very well. But we've also have a tendency that we've always been lucky in that everything tended to be regional and localized, so that unimpacted areas could then serve to support the areas that are impacted. And I don't know very many planning scenarios that really prepared us for something so global and something that happened so quickly. But it does get to the question of how do then we share this information up and down the stream with the manufacturers and the distributors and the GPOs and the healthcare systems. So what data should we know? What metrics should we build? And as you sit as a CFO or in the C-suite of a healthcare system, what do you wish you could measure your supply chain on? Instead of traditional metrics like supplies as a percent of net revenue, or supplies as a percent of some denominator, or your savings goal, or your inventory reduction goal, or your supplier reduction goal, or your SKU reduction goal, or some other goal. In addition to that, what are the other set of balanced metrics that we wish we would have known and should know going forward for our healthcare supply chains? So how do we measure things like supply chain sustainability or agility and redundancy or flexibility or security? Pick any number of those descriptive words and say, how do we measure that? How do we take into account for the value of, say, having a supplier that manufactures in my state or in my country versus in another country? Or how do we measure that in this particular product category, every major manufacturer of that, regardless of what label is on the box, comes from the same country? Or how do we track raw material source information to try and build out redundancy in other sources and be willing to pay for that? So you can't go on this constant, cheaper journey without giving up and opening yourself up to more risk, as we're all dealing with now. And so the ask of this group is, we want to hear from you. So as HRMM is working on this program and all the work that has gone on pre-COVID-19, we've been asking ourselves, and I'm asking you to ask that same question. What do you wish you would have known? And not even being so concerned necessarily about, do we have the ability to know that information? Because we can always build systems and tools in our automated world today to find ways to get to it. And what do you wish you would have known? What are some of those data fields or metrics that you think could have made a difference in your ability to respond to this situation or similar situations coming up? And I'm going to turn it over to Mary Beth for the CFO perspective.
Thank you, Steve. I think the other thing that Steve, maybe you did not mention, is that you are actually leading this task force to develop not only what are the leading indicators, but also what is a significant opportunity for supply chain and leadership is these creative metrics that don't exist. So really do join us in helping us to develop what doesn't really right now currently exist. Additionally, there is data, as Steve and Karen and I have been talking and preparing for this. Some of this data does exist. There's a lot of data that exists. We don't necessarily share the data because we're concerned about, we're going to share pricing information and things like that. And so I would ask Karen and Steve for just a minute to talk briefly about why and what you see is why do we not share data that we currently have as well?
Well, I think you've hit on one of the key things, and that is price sensitivity. I think, and when you say the word price, certainly there's sensitivity about the price of a procedure, a negotiated price that we've had, or the price of a product. And historically, that has been kind of the thing that stops us in our tracks. But the reality is there is plenty of data, particularly when we're talking about critical supply availability. And I'm also going to mention in a couple of slides, because I realized I skipped over a slide related to clinical evidence, clinically relevant attributes, those kinds of things. There's plenty of opportunities. It's just not been, I think it is more of a cultural issue than it is a technological issue. But I will argue that it is also a standards issue. We don't call the same thing across healthcare. I think that would deliver some tremendous value. Steve, any comments?
Absolutely true. I think everybody agrees that sharing data can drive a lot of value. It's coming up with the right format and the right forums in which to appropriately share that information and in ways that appropriately aggregates and satisfies all of the appropriate security concerns around, what information is shared and with who, especially as it relates to pricing, or especially when we try to do work that ties product to outcome, of course, because, we have to be cognizant of patient information, et cetera. But I would submit is that while standards is absolutely critical, and it's why retail has a lot better data up and down the entire supply chain from raw material to final consumption than healthcare supply chain does. And we have to strive to get there through the application of those standards and the understanding that and especially when it comes to just product level information like consumption and like inventory levels, et cetera, there's a lot of product information that is not PHI and it's not HIPAA related. So finding ways to appropriately share that information, because we do have an obligation to make this information work better for the good of the patients and the good of all of the stakeholders up and down the supply chain.
And I think
just quickly. Oh, go ahead, Mary Beth.
No, that's all fine. That's fine, Karen. Go ahead.
Well, I apologize because I think this also delivers, and I've looked at some of the questions that are coming in, and I want to be cognizant of giving folks time to ask the questions and for us to address them. But one of the things is that this really does need to be a team sport in terms of how do we make decisions. So if we're, one of the things we've absolutely heard, and it, is those clinicians on the front lines who are being asked to use something completely different, or that are being asked to, use something longer than they're used to, or to, to reuse something after it's gone through some appropriate reprocessing, et cetera. These are not things that happen in routine clinical practice. And one of the things that we've learned from the clinical world and supply chain has really tried to emulate is this desire to reduce variation, because you reduce variation, you do improve quality. And even, and if you're a clinician too, I mean, I've heard stories about, suddenly I'm using, yesterday we were using pink gowns and today they're green and tomorrow they're blue. And it's not just a color, it's actually how you use them. And that creates tremendous stress for those frontline clinicians. So this use of, and we've got some access to some research here, that ability to get to different kind of data. So certainly you're going to be looking at cost. Hopefully you're going to be looking at what is our risk, and if this vendor can't supply, do we have the opportunity to go here? But you want to allow the clinicians to also look at that clinical evidence about data. And one of the things that I think we'll be seeing is a lot of evidence coming out of this experience, whether it's on, when is it appropriate and when don't you need an N95 mask? What is an appropriate way to reprocess equipment, et cetera, and using that evidence and allowing the clinicians to be helping you make those decisions. This really should be collective decision making, bringing the expertise from multiple players. Now, I know we're asking you and giving you a lot of different kinds of things to think about for the future, but we also wanted to make sure that you had some resources. Wanted to make sure that you knew about AHRMM's site, where they are providing a lot of free information, just like HFMA is. And in particular, I want to show you a piece where we've been vetting and posting. I think we've done about 400 different non-traditional suppliers and are posting new ones every day based on different kinds of equipment. So if you're looking for specific equipment and your traditional vendors or those that you know about aren't available, you could go there. We've got some resources on the GHX site where we took these essential product lists that were developed by the World Health Organization, the CDC, work from groups like McKinsey, and we built out these lists. You can see them. This is just a screenshot over here. And if you were to click on one of these, you would get a spreadsheet, and this is just a look at it, but you can start seeing, hey, you know, we always bought the N95 from 3M. The 3M can't get it to me. Is there another product that's comparable? Is there another vendor who sells it? Is there another manufacturer who makes it? How am I managing this under UNSPSC codes? And we continue to develop this as additional products, including pharmaceuticals, become in short supply. Then we've also got some complementary access to this clinical evidence that Lumir has put together, which is really, they've looked at 35,000 different devices and drugs and all the best of the clinical evidence and tried to get it in one place for you to be able to look at it. So again, you look at products from multiple perspectives. Is it available? Is it clinically equivalent? You know, what is the price and what's the impact on my bottom line? And you have these multiple different factors. And Mary Beth, you know, would love to, because you have always been so good at reaching out to the other kinds of leaders in different functions within your organizations. If you had a few thoughts on that before we move on.
Well, I was just going to say, in my history of being involved as a finance professional, I'm going to harken back to what Steve was talking about, all the different metrics. And it is very interesting to see how we are growing and morphing in the supply chain area. Certainly, I have had an increase in respect for everything that the supply chain does, how it is viewed, and I have always thought of it more as a strategic partner, because as our reimbursement models are changing, we are accountable not only financially, but it's just the right thing to do to take the best care of our patients. And it is sort of balancing a focus on the financial outcomes for sure, as well as the clinical outcomes. And something that the group can look up as well is from an AHRMM perspective, there was a CQO movement, cost, quality, outcomes, and the intersection of how all of those interrelate. And as Karen was saying, Karen and I have done a lot of speaking together about the importance of supply chain. And so I would just encourage everyone at this point in time to really take on a leadership role. You are in the limelight right now, all the work that you're doing, and really take advantage of that and move your organizations forward.
Thank you, Mary Beth. And then I want to show that HFMA has also some tremendous resources as well, if you have not seen those. And then move to some final considerations, and then we can get to some questions and answers. I want to give you I was on a call with the Institute for Healthcare Improvement last week, and it was all about crisis standards of care. Which is something, known to many clinicians as they look at, crisis situations. And in that case, I was thinking a lot about allocation of products. And I'll tell you, the reality is, and we saw this when COVID-19 was really peaking, is that typically allocation, when a distributor or a manufacturer is not able to fulfill everybody's order, they start allocating, you get this much, you get this much, you get this much. Unfortunately, we've often done that based on, do I have a contract with you, and who, what's my purchase history with you? What's my bigger customer? And I think this is a perfect example for us to be able to align crisis standards of care with supply chain allocation. But we need to know when those triggers are. Mary Beth or Steve, you want to make any final comments? And then we can go to questions and answers before we run out of time.
I'd go to the questions.
Yeah, I think so too, Karen.
So I have a couple of questions for you. The first one is, who or what is the gatekeeper to trigger the supply chain from just-in-time cheapest to emergency reality, sourcing, or C-suite responsibility?
I think that gets back to that issue of it's not one, because if you make the decision based on one viewpoint, you're not taking in the other factors. I think when you get into emergency reality, we've also seen that, that's where it's a matter of, it's not just a decision made in the hospital. It may be even not a decision that's made by, multiple hospitals and healthcare systems in the region, but you get players like local government, state government, federal government. That's the purpose of that scenario planning, tabletop exercises, because in some cases, the rules change. In other cases, it's something you can be thinking through, but I would love to get Steve and Mary Beth's thoughts on this.
It's a team sport. I agree. I mean, it's, ultimately, obviously the supply chain executive has a lot of responsibility in helping, the leadership team understand when we need to make those kinds of strategic shifts. And we should have already talked through, what are our data-driven trigger points, at which point we do those. But it's a team sport for sure.
Yes, I agree. I don't think that there's one specific part of the organization. I think it has to be really looked at not only from and actually we were talking about that in prep for this discussion, which is just in time sounds really good for certain items and certain circumstances, right? But is your facility actually configured to have more inventory, or do you need to go out and get warehouses? We were talking about that. That would be a perfect opportunity for different providers to go together if they needed more space. So definitely I think it's a team sport within the organization and also across a region.
Thank you all. So we have another question. I think one of the other ones that came in, you guys answered. A lot of the shortages to date have been for PPE and ventilators. What about drug shortages? Are the underlying issues?
Yeah, there are. Yes, are there drug shortage concerns? Absolutely. And I've been on, as many people on this phone have been on numerous calls, regionally, nationally, for definite concerns related to potential drug shortages, current drug shortages. I think I recently saw a list of about 35 therapeutic drugs that are at risk for shortage. There's a lot of the same reasons. If you look at the APIs or the active pharmaceutical ingredient for a lot of these drugs, the source material, a lot of those sources come from one place. And in many cases, one country might be the only source for a lot of APIs for the pharmaceutical manufacturing industry. And so if that country decides not to let any of the APIs out of its borders, we have a problem. And so how do we find ways to bring more APIs, into other places of manufacture? So it's a lot of the same things that we're dealing with PPE and other things. Similar to when the hurricane hit Puerto Rico, we found out, how many things are made in Puerto Rico that we all rely on. So, not having that redundancy is impactful to all supply chains, and even non-healthcare supply chains are severely impacted by those same circumstances today.
I got to say, this is one of the areas where, I see some, I'm excited about some of these advanced manufacturing capabilities. We've looked at 3D printing. The reality is not every country is going to be able to make everything it needs. There are raw materials that just don't exist in every single country. But we are seeing things like one drug company I was looking at, they have this thing called portable continuous miniature manufacturing, which actually allows them to put the manufacturing plant in a truck and take it closer to where things are needed. I quite frankly think we might even see hospitals and healthcare systems getting a little bit into the manufacturing business, et cetera. This is where technology can help us solve some of these problems. But again, it's not something we can do on our own.
That's great feedback. Thank you, everyone. And we have reached the end of the program today. Just going to ask the speakers if they have any closing remarks.
I would only say thank you for your attention, and let's continue the conversation.
I agree. Thank you, and please send in your thoughts to the email address we provided, arm@aha.org.
And I would just like to thank everyone for everything that you're doing for your organizations, your patients, your employees. You're doing heroic work. Thank you.
Amen to that.
Thank you, everyone. So we have reached the conclusion of today's webinar presentation. I would like to thank the speakers for this great information today and GHX for sponsoring this very timely presentation. We hope that you found the presentation informative. If you have further questions about this webinar, you may email them to HFMA's Resource Center at resourcecenter@hfma.org. The Resource Center staff will assist with any questions not answered during this webinar. Be sure to sign up for upcoming webinars via the HFMA website at hfma.org. Thank you again for your participation and have a great day.